So the multi-organ transplant program at Johns Hopkins, as it relates specifically to the heart failure and heart transplant program, refers to a combined organ transplant that includes a heart transplant along with another organ. So specifically that includes a heart transplant and a kidney transplant, a heart transplant and a liver transplant, or a heart transplant and a lung transplant performed concurrently. It also includes the possibility of 3 organs being transplanted at once, and generally that would be a heart transplant, a kidney transplant, and a liver transplant performed concurrently. We look at all patients that have heart failure, and when a patient comes into clinic or we see them in the hospital, we evaluate them, and if we find that they have either clinical, radiographic, or historical signs that may predispose them to having not just heart failure, but another organ being injured, then we engage our abdominal or other thoracic transplant teams and proceed with the evaluation from there. So as it relates specifically to the heart-kidney transplant program, based off UNOS guidelines, we consider patients for both heart and kidney transplant when they meet specific criteria, including a GFR less than 60 for a period of time, as well as a GFR less than 30 at the time of listing. But we take a bit of a nuanced approach. And not all patients that have a GFR less than 30 or close to 30 necessarily need a heart and kidney transplant at the same time. And there are patients that we feel may benefit from a heart transplant alone, followed by a kidney transplant at some point in the future with a program called the Rescue Kidney Program that's been designated by UNOS. So we look at other factors such as the size of the kidney in conjunction with the nephrologist and the abdominal transplant team. As it relates to heart-liver transplantation, we also use a lot of subtle signs, including the patient's history. For instance, patients with adult congenital heart disease, in particular patients who have a history of a Fontan, often are at risk to have liver failure or liver disease. So in almost all of these patients, we'll get a liver biopsy, and we're very aggressive about that in patients who have historical signs of high venous pressure or high pressure on the right side that may lead to liver disease or liver failure. I think an aggressive approach of evaluation consideration leads to the best possible outcome. So in the preoperative phase, the patient journey is similar. As I said previously, they get worked up either in clinic or in the hospital, and we go through a similar constellation of clinical tests as well as imaging in order to evaluate the patient and work them up. They'll meet the whole transplant team, and if they're being evaluated for a multi-organ transplant, they'll meet the abdominal or other thoracic transplant team as well. Intraoperatively, the surgery is often a bit longer and depends specifically on what multi-organ transplant we're referring to. Patients who are undergoing a heart transplantation and kidney transplantation will often take 2 trips to the operating room as opposed to a single trip to the operating room, as we found that that optimizes the blood flow to the new kidney in that setting. Intraoperatively, patients that are undergoing a heart and liver transplantation, we have an approach that we feel works very well and we've had very good outcomes with, where we complete the heart transplantation first, and then we support the patient on ECMO for the period of the liver transplant and allow them to get through the liver transplant safely, take them off ECMO at the end of the case, and bring them to the ICU afterwards. From a patient standpoint, it's all one period of time in the operating room, but we like to do it in a way that optimizes blood flow to the heart and the other organ at the same time. Overall, I would say that we're a program that wants to see all patients in consideration and evaluation for transplantation. Patients that may not be candidates at other centers may actually be candidates for multi-organ transplant at Johns Hopkins. This includes patients that may be highly sensitized and may not be candidates for multi-organ transplant at other centers for those reasons, as well as patients who are high risk because of other potential comorbid conditions that we may be able to offer therapies to here at Johns Hopkins.